So, just to tell you a little bit about Julie Majors before she comes to give her 5 minute presentation, I will say that Julie certainly is someone who, if you're in the state of Maryland and you are concerned or want to know about what's happening to men and women behind bars, Julie is certainly a person to know. Since 2016, she has been the leader of the Maryland Prisoners' Rights Coalition. She has over 10 years experience in advocacy for incarcerated individuals, and she works specifically with individuals who have mental illnesses and those who have substance abuse disorders. But again, I would say, at least with my connections with Julie, that she really is a person who has a wide range of knowledge about what's happening to our men and women, family members, loved ones behind bars. And so we welcome you, Julie, and thank you for being with us this evening.
Thank you so much, and thank you for those kind words. And thank you for having me. Today, I'm going to talk about correctional healthcare. To get right to the point, it's anyone here who's worked with me or knows me knows that that's near and dear to my heart. And the MPRC has been working on issues of correctional healthcare for a really long time. Notably so, as you had mentioned before, that this issue is quite a monster. And it's been going on for many, many years. We also field complaints on a weekly, daily basis. And I have to say that is our top number one issue that comes through our door, our mail, and through the families is a lack of correctional health care. This is everything from chronic illnesses not being addressed, surgeries that are not being given, literally reports and records of people that are sick with open wounds and injuries laying on their floor and not being addressed. The medication issue not being given, not given properly, wrong medications given, people being given other people's meds, dosages that are absolutely off the charts incorrect, infectious diseases that are not being addressed, notably so, people that were released during COVID with either staph infections or MRSA that brought those home to their families. These are deplorable conditions which just equal a blatant lack of care and disregard for these people. I want to mention that one of our big clients, we happen to have the ability to pull all of his records. And over a 5-year period, this person has MS, and we took those records and went to Johns Hopkins. The head of neurology and several other physicians reviewed everything in his file from start to finish and found such a complete lack of care that they basically contacted me back and said, you need to contact an attorney because this doesn't even meet a minimum standard of care. We located through this investigation consistent levels of fraud, records that were blatantly deleted, because when you order them over time, you were getting different records from the records department, which is absolutely ridiculous. Incorrect meds that he was given that he was forced to take, or he would have been sent to lock up. Anyone who's directly impacted knows that does happen. Denial of disability aids for 5.5 years, and many, many more violations. And I hate to say that we were blessed enough to be able to get these reports and to get them from an outside independent physician that was able to kind of show this. And this is one person. These are reports and evidence that we are collecting for multiple people. These kinds of incidents are happening every single day. And it's really, it's a very egregious situation. During COVID, when Corizon requested an absolutely exorbitant amount of money for COVID care, advocates kind of jumped in on this to show the comptroller and the treasurer and BPW that not only was COVID care not happening, but that these providers were blatantly ignoring their contractual agreements. They're not they weren't giving chronic care, yet they continued to request money. And they requested a $29 million contract increase, even though they were unable to fulfill that contract. The hearings in May of 2020 analyzed the issue of COVID care and were a market response to this issue that has been going on for much, much longer than COVID. I hate to say that it was a blessing of sorts because it brought something to light that is historical. These historic failures have been going on for so many years, I can't even count. Peter Francho, our comptroller, stated, I guess the concern here is that we're simply reimbursing this company for its own failures as far as implementing the contract that they signed to and agreed. And here we are paying extra money and attributing it to COVID-19. That is pretty profound coming from our comptroller, that we are able to highlight these massive amounts of failures and years of money basically being thrown away and wasted. In June 2020, Prison Policy Initiative did a survey of how correctional facilities have handled healthcare during the pandemic, and Maryland received an F. They came back later in September of 2021, and we've only moved up to a D for healthcare response during this pandemic. I think that's pretty bad. So why do we need oversight? First of all, this is absolutely horrific. It's a horrific way to treat human beings, and it's a violation of rights, making it a huge liability. Second, it's an absolute waste of tax-paying dollars and drastically affects reentry outcomes. When we talk about collateral consequences, this is one of them. The way that we are treating people behind the wall is exactly going to affect them when they come out. It's huge. And it also makes it a public health issue. If we are debilitating people with their health while they're incarcerated, they can't be expected to be productive when they re-enter society. We conducted interrogatories with the department a couple of years ago, and that, coupled with our most recent response from the department, shows that the majority of any oversight that they do have is completely internal. I think we can all guess what policing yourself accomplishes, which is pretty much nothing. Literally complaints, and we have actually done this where we've contacted the Office of Inmate Health or another one of these offices that they list as an overseeing entity, and they basically state that their process is that the grievances go to the healthcare provider and they concur with them. That is not oversight. That is not independent, and it certainly doesn't meet a standard of care. Several of the entities which they do list, again, as being an oversight committee, don't actually oversee healthcare issues. They also do not receive and address any actual prisoner healthcare complaints. As well, the entities and offices are not comprised of healthcare experts, not social workers, no directly impacted voices, or anyone that could actually come close to judging or grading what is and what should be a health standard of care. From all of our research and evidence, the best way to just begin to correct these issues is to have an independent oversight board to address this mountain of failures and problems associated with correctional health care, from medical to mental to dental. Current practices are costing exorbitant amounts of money to the state, to our communities, and it's costing lives. We are introducing a bill that will establish a proper independent oversight board that includes those healthcare experts, includes independent voices, and we're asking for your support. The other, I'm going to push this over to Allie Preston, who is also with the MPRC, to speak about the medical and geriatric parole bill. Allie?
Hi, everyone. So as Julie said, we're also working on creating a new system for medical and geriatric parole in the state. What we have now is a really fragmented system. The code for geriatric parole and medical parole don't even appear in the same places in the Maryland Code. One is in the criminal law code and one is in correctional services. So sort of the first step of this is making sure that we move the geriatric parole, which is currently in the criminal law code, to its appropriate location in correctional services. And then from there, we have just some minor tweaks that are really aimed at making sure that these are processes that people who are incarcerated have meaningful access to. So for geriatric parole specifically, it will be working to ensure that individuals who are 61 and over are being evaluated for their eligibility for this geriatric parole process. And it will be focusing on having a more dynamic risk assessment than what is actually available to incarcerated individuals now. We know that in 2020, there were about 6% of the population who were technically eligible for geriatric parole based on age, but there's no system currently in place that ensures that these individuals will be evaluated for the appropriateness of geriatric parole. And then for medical parole, the big factor here is making sure that when these decisions are being made, that they're actually being informed by the best medical evidence that we have. Currently, there's one factor that's listed in the statute that tends to sort of swallow up the parole board's assessment of whether or not somebody should be eligible for medical parole. And that's based on something called a Karnofsky score, which is essentially just sort of a functional analysis of what people are able to do. And it ranges from 0 to 100, with 0 to 40 being the lowest functional ability for individuals. And that's listed as unable to care for yourself. And it requires the equivalent of institutional or hospital care. And it means that your disease is progressing really rapidly. And for certain low scores, this could mean that you were even days or hours before dying, before you actually get access to this process. So rather than focusing on a Karnofsky score, which the parole board essentially says, if you're above a 40, which is the highest part of that low rank, you will not be assessed for medical parole. So even if you're unable to work, even if you're unable to live on your own and you still need support for a lot of your functional needs, as long as you can take care of 1 or 2 functional needs on your own, you will not be eligible for medical parole. So what our bill will do is to have the primary focus be on a medical assessment that is either done by 1, the institutional healthcare provider, or 2, actually give the incarcerated person the opportunity to request that an outside physician provide a medical analysis and report of their health status. And then again, elevating that so that the medical report, rather than just this baseline functionality assessment, is at the heart of the medical parole system. The decisions, excuse me. So it's really just ensuring that these processes that are intended to be compassionate release programs are actually going to be made available to the individuals who they should be made available to.
Thank you so much, both Julie and Allie. And we certainly look forward to, looking at the drafts of the bill and having input, certainly based on the information, that we get from individuals who write us, so that we can make the bill as robust as possible. But thank you so much for your leadership on that.
Thank you. And we will send that over to you, the copy of the bill draft and all of the information that supports it.
Great. Thank you.
Thank you all.